get started. All right, so I am really thrilled to introduce Sanjay Basu to you. Sanjay is an assistant professor at Stanford and part of the Center for Poverty and Inequality, one of 3 national poverty research centers. Received his undergraduate education from MIT, his master's from Oxford, his MD, PhD from Yale, and then most importantly, his training in primary care from our primary care training program. We're very proud of that. In 2013, he was listed as one of the top 100 global thinkers by Foreign Policy magazine, and in 2015 received the New Innovator Award from the Office of the Director of the NIH. As you will hear, Sanjay does some really outstanding work that I'm sure many of you will be interested in and relate to, and it's a great example of someone at the intersection of doing outstanding scholarly work that informs policies and public health and the issues that we all care about. So, Sanjay?
Thank you for that introduction. It's nice to see so many familiar, friendly faces. So I thought I'd chat a little bit about what I think is a really interesting conundrum, which is, from an academic perspective, a problem of evaluation, which is, if we believe the last several decades of literature in social epidemiology, then social determinants of health are a profound influence on the patterning of disease and disparities in health. And hence, one might conclude that we should study social policies. By social policies, I mean everything from fiscal and regulatory policies affecting how much taxes you pay or subsidies you receive, to policies around neighborhood design, household level supports, income, employment, as strategies to influence health and health disparities. But I would argue that perhaps the central challenge to doing this work is that we can't easily, sometimes we can't ethically, and sometimes we can't fiscally do randomized controlled trials. So of course the reason that we love randomized controlled trials in medicine and to some extent in FE or public health is because of fairness, that is trying to reduce bias in our evaluation. And so it's very nice to be able to say that you randomize people to your intervention or not, and your intervention clearly had an unbiased impact on their health. But imagine some of the most interesting and compelling social policies that we describe as being potentially helpful for health today are policies like perhaps Berkeley's soda tax. It would be very interesting to try to randomize a population if they tax or not. Imagine you get really high attrition from your intervention to your placebo group. And other policies that are regulatory in nature involve neighborhood designs. Colleagues in the physical activity literature were talking about making walkable cities. It'd be really difficult to randomize city council members to decide to make more walkable or less walkable cities and then compare. And so, as we all know, living in San Francisco, there's this phenomenon of what the economists would call endogeneity, or what we might just call self-selection. That is, places that are progressive, pass progressive policies, attract people who like those policies, and vice versa. I grew up in Texas, and so there is massive self-selection around the people who I grew up with. So, you know, I learned how to shoot a gun at 4 without my parents' consent, because my neighbor thought it was a good idea.
Awesome.
Cool, right? We'll come back to that. So we looked at, you know, how in the absence of being able to practically do randomized controlled trials in most cases, with rare exceptions, could we do more rigorous evaluations of social policies' health incidence? We recently did a review trying to find keywords around policy evaluations, social policy evaluations in health. And the vast majority of articles that we found were commentaries suggesting that either a particular social policy should be advanced to improve health, or that more evaluation should be done of social policies and their health impacts. There were a much smaller subset, about 60 or so articles, that actually did some sort of evaluation of a social policy and its health outcomes. And of those, about 46 met some basic quality criteria, like having a clearly defined data source and a control comparison group and so on. A few of them were pre versus post analysis that compare your outcomes in health after a policy versus before. And I'll argue that that's probably the one that is often popular in public health and one that we should run away from quickly. And then there's several others that use all sorts of interesting vocabulary. In blue, I put what I would call sort of classical or older approaches, difference and differences, propensity score matching methods, which I think in public health we often use. Regression discontinuity, instrumental variables. And in green, I put ones that are maybe less familiar, synthetic control, near-farm matching, very new methods. What I hope to do by the end of this talk is communicate to you a rubric for thinking about the problem, such that this vocabulary is familiar, and that one might be able to look at this vocabulary and say, I kind of have a sense for when these approaches might be useful or not, what their hidden grenades might be, and when I might think of using them myself for social policies I'm interested in evaluating. To provide a broader framework that isn't just terminology, I thought I would discuss three major challenges that I would argue exist in the public health literature on social policy evaluation. And these methods fall largely under one of these three. So if you don't have the joy of a randomized control trial available because of budgets or practicality or even ethics, some of the key challenges that I think we can overcome. One is distinguishing whether the policy effect is really the policy effect or just a time trend, or pre-existing differences between groups. So let's take the Berkeley soda tax example. Soda, thankfully, or sugar-sweetened beverages generally, are actually reducing in consumption at a national level and also in Berkeley. So how does one know if one measures soda consumption before the policy went into effect in Berkeley and after? If this is just culture, it is Berkeley after all. Culture is found influence. And cousin who moved to Berkeley to do a PhD in rhetoric, which I think is the coolest PhD, quickly adopted bright red tight pants and a fixie and drank aloe vera juice within a week or two of Berkeley. So something cultural, right? Even if we can't measure it easily in a study, is potentially going on. And pre-existing differences. We could compare Berkeley to San Francisco, but we can match populations based on income and race, ethnicity, and whatever else we think is comparable. But again, there's sort of that gestalt, what I would call unmeasured confounders. There's something about Berkeley, right, that is maybe difficult to find a matching control population. And so the second point I'll discuss is what can we do if we don't have a fantastic comparison population? We'll live in San Francisco here. I feel like a standard retort on grant applications you must submit is, well, this is a fantastic intervention in policy, but if you were in Ohio, we would give it to you, right? Like, somehow Ohio is more representative than everybody else. Even though by definition it's not. Anyway. And then the third is perhaps one of the hardest and stickiest, addressing unobserved confounders. Those gestalt factors that isn't just an explicit variable you put in your regression that says, oh, I matched by income, and similar income people are different with my intervention or not. There's all sorts of factors that we can't even observe. Could we use some random variations, even if we think they're not present, in order to list those? I'll come back to that in more detail. So let me give you an example and start out with one of the more classical approaches, an approach that I've seen routinely in big journals like the New England Journal and JAMA. Is an effect really from the policy or not? Here's one of the challenges to trying to address this question. Suppose we look at tobacco control in California, a model state for tobacco control, some might argue. And here are cigarette sales per capita in packs, not the greatest measure, but some measure of tobacco smoking since 1970 to 2000. And as many of you know, around here in 1989 was a big proposition in California that really introduced some major clean air laws, made it more difficult to purchase tobacco for youth, and a number of other things. And if you look at the graph and look at 1989 and afterwards, there's quite a precipitous decline in tobacco sales rate. But also beforehand, there's somewhat of a decline in tobacco sales as well. So you can say, well, I want to know how much the policy affected these sales. So I could kind of do a pre-post comparison. I could say, here's the trend beforehand, and it kind of goes down gently. Kind of goes down gently, and after the policy it goes down even more than it was going down before. Fantastic. Well, one of the problems with that pre-post analysis is where do you start the time trend that you're going to choose? Should you start it at the peak? You get kind of a rapid decline. Should you start it as soon as you have the data? I have data from 1970 here. You have kind of a flatter curve. Should I go back and dig in the historical archives? I might have a very flat curve to compare against, and my false effect looks huge. There's not really a great answer. And I could compare California to other locations, but you get that accusation against you in California. You're not Colorado or somewhere else. So what do you use as a control group? So a very common approach that's used is the difference in differences approach. This tries to account in particular for that time trend factor and say, suppose we pick some control population, Colorado. And what we would argue, and I'll show you why it's such a hard argument and what you can do to overcome it, is that big national trends could have been affecting tobacco smoking rates, right? Like the overall cultural milieu, which was increasingly against tobacco smoking. Or economic factors, recessionary factors, how much income people have, which could favor or disfavor smoking. And you try to compare over time, both before and after the policy, what did California do versus what did Colorado do? And say Colorado, you would argue, is capturing some time trend in national trends in smoking, and whatever the difference is with how much Colorado changed versus how much California changed, the bigger change in California might be attributable to California's unique policies. You can see how hard and contorted the argument becomes quickly. You have to make a couple assumptions. One is that Colorado and California were sort of parallel in their tobacco sales. You can check that before the policy happened. And the second is that you assume Colorado is such a great control group because whatever would happen nationally, changes in the economy, changes in national tobacco policy, that Colorado can mirror what would have happened in California. As you can imagine, it's really quite challenging. So I'll come back in a moment to how we can overcome this big set of assumptions. But I wanted to start with this because difference in differences is an extremely popular method. One sees it in major journals. Here, for example, is a really nice article in the New England Journal from a few years ago, asking a very important question. Does Medicaid expansion reduce mortality? Very important current health policy question. And they used a difference in differences method. On the left is mortality rates. In red are states that chose to expand Medicaid. And in green are states that didn't. And as you can see, before Medicaid expansion, which is the left half of the graph, there was a rather parallel trend in mortality between the two sets of states. Fair enough. After the Medicaid expansion, the control states continued to have kind of a gentle upward slope in mortality, while those states that expanded Medicaid had a gentle decrease in mortality. This is deaths per 100,000, so a gentle decrease is actually a profound number of actual deaths. Okay. One can see also that Medicaid enrollment did what one would expect. Beforehand, Medicaid enrollment was declining overall in both sets of states, and in the expansion states in red, naturally Medicaid enrollment went up quite a bit. And the control states had kind of stayed more or less consistent with the prior trend or flattish. Okay. So you would have to argue here that the control states are reflecting some national trends in insurance enrollment and overall causes of mortality, and that what the difference is between that trend and the new trend charted by the expansion states is attributable to the policy itself. The authors did one thing in addition here. They tried to additionally say, well, we know these states are different, right? Who are the states that choose to expand Medicaid? One could call them the Obama friendlies. And who are those that decided to not expand Medicaid? Maybe the Trump friendlies. So you could say that overall, maybe the national economy was doing things that influenced mortality, or national rates of disease were changing in a way that's captured by this control group. But also within the expanding states, there's something unique about them, right? They tend to be a bit more blue. There's all sorts of other things going on that are unique to within states. So these authors tried to do something in addition. They said, who is Medicaid expansion affecting? Presumably the 19 to 64-year-olds. Right? The younger kids have S-chip or others. The older people who most have Medicare. So if there's changes in mortality among, let's say, the 65 and older crowd, that's not probably the effect of the policy. So they not only subtracted out what the control states were doing in terms of time trends, they also subtracted out what older adults within the expansion states were doing. Because that might be other state relevant stuff. You know, changes in air pollution, all sorts of things that could be going on to conservatively estimate how much the Medicaid expansion is going on. But you can still see that it's kind of a difficult rhetorical argument to make that you have a reasonable control group and that you're really detecting a policy effect, not a million other things that could be affecting these large-scale numbers. Furthermore, there are spillover effects that make this difficult to do. That is to say, if expansion states are doing something, they might be affecting neighboring states that aren't. One sees this, for example, in various welfare income support programs. What happens if a state has a more generous program and another state doesn't? Near the border, there's a number of people who use their relative's address in the more generous state. You see that all the time in California compared to Nevada. So difference in differences methods are very popular in public health literature and medical literature, but they pose these challenges, and I'll talk a little bit about what we might do to perhaps overcome them.
Was there an example of the triple differences?
This one, triple differences, is very hard to physically illustrate, so this is just the difference in differences. Two differences.
What you're saying is subtracting out the control state and then subtracting out
The 65-year-old, that is the triple difference. Exactly. So in a regression...
In other words, because it essentially is making a cleaner comparison, not because of an actual... When we say difference in difference, we're talking about the difference in time.
Yep.
And the difference between the two states in the differences in time.
Yep.
But the triple difference is actually simply looking at a cleaner population in this example. I don't see another subtraction that is relevant.
It is actually equivalent to doing another subtraction, because what you're doing is adding in another set of interaction terms with, in this case, age. So if you add in another set of interaction terms with age, now you're not only interacting with time and control versus experimental state, but also whether the person is younger or older. And the math works out that it's actually equivalent to taking a third difference, the difference over time between older people and the difference over time between younger people.
So in that way, I was going to say, but isn't that equivalent to doing a stratified analysis only in the middle age group, you know, in the non-old group? But what you're saying is actually...
It's sort of, but it's like actually taking the difference in the coefficients between, if you were to do like a subgroup analysis, you would say, let's subtract out from the younger group whatever you saw in the older group's subgroup analysis.
It's not just a stratified analysis.
Right.
Let's just look at this group.
Exactly.
And make that comparison
Right.
in our heads.
It's actually trying to adjust the coefficients. Yeah. Okay. So another common technique, let me come back to how we might overcome some of those dilemmas with this common method. Another common technique that I think is even more popular in some of the public health literature, and many of you have used, is propensity score matching or some other equivalent matching techniques. Right now, a very popular one is coarsened exact matching. But they're all kind of the same. The theory is, I have a bunch of people in Berkeley who I've studied before and after the soda tax. And I have a bunch of people who I've surveyed and studied in other neighboring towns, but they're not Berkeleyites. Right? What do we call Berkeley people? So, they're somehow different, right? So, how might we make a fairer control population? A popular method is to say, let's just match individuals to individuals as closely as possible. So I have one subject over here from Berkeley who's a 35-year-old Indian male. Okay? I'm going to find another 35-year-old Indian male from San Francisco. And do that for as many demographic and other variables I think are important as I possibly can. Right? As much information as I can, I'm trying to find an almost identical twin in all those features over who wasn't affected by the policy, and then try to produce a fair comparison. It's very reasonable. There's two things that make it difficult. One is this problem called common support. That is, I have to find a 35-year-old Indian man in Berkeley and a 35-year-old Indian man in San Francisco. Right? There may not be great pairings available, especially we were doing a study in Santa Clara. There's many twice-an-E speakers around who describe their race ethnicity in a way where we can't find a match outside of the county to compare them against. Okay. So common support is a problem. You can only match people who are sort of common enough that you can find a twin for them. Hence, your inference is only valid on those folks and maybe not on others that you want to generalize. More important, I would argue, is the less discussed problem with these matching methods. There's a fancy name for it: strongly ignorable treatment assignment. A gobbledygook way of saying the following: whatever I match on, age, sex, race, ethnicity, income, etc., I assume that there's no other factor out there in the world that could possibly affect both the likelihood of getting exposed by the policy and the health outcome, other than the factors I've included. So I assume that I have every possible relevant variable in my matching system, my matching algorithm, and nothing else could affect whether the person has been exposed to policy or not, and what their health outcomes are. In almost every case of social policy, this is nearly an impossible assumption to be true. Okay. Remember those Gestalt factors that make you a Berkeleyite? Right? There's something there that attracted the person to living in Berkeley, right? And we might not be capturing it by matching on age, sex, race, ethnicity, income. There's some other things that we haven't asked. They're usually not in health databases that might profoundly influence whether a person wants to live in Berkeley and not somewhere else. Fair enough? A nice example of the problem with propensity score matching is this. There was recently a study, Hillary Sullivan and I were critiquing it, in which food stamps and the Supplemental Nutrition Assistance Program was associated with obesity. What they said is, here's a group of people who receive food stamps, and here's a matched group. You know, same age, income, race, ethnicity, a few other variables that they thought were important, who look really similar, who aren't on food stamps. And guess what? The food stamp users are more obese, significantly. What might be a dilemma? There's all sorts of unobserved factors that also affect why you decided to be on food stamps when you're low income and somebody else didn't. Right? Degree of rurality was not one of the matched pairs. If you live in a major urban zone, chances are it's a little easier to sign up. Various aspects of your state. Some states fingerprint you when you're signing up for food stamps. Okay? All sorts of things discourage or encourage a person, and we may not be able to capture all of those, but many of those may very well be related to the type of neighborhood you live in, whether that may be an obesogenic place, etc., etc. Okay? So propensity score matching is great in theory, but that little caveat is actually, I think, a big caveat that we should be grateful for. What could we do? Okay, so now on to some solutions, given these two common methods. One method, and I think is particularly interesting for people studying health disparities, is called a synthetic control. It's relatively new. Been around since 2000 in the statistical literature, but in the public health literature, maybe only since last year, 2015. So what is this? Imagine doing a difference in differences, like we did before, but here you try to construct a better control group. So let's say you're trying to study California's tobacco legislation and say, hey, after the tobacco proposition, did California really, substantially do better? And you can compare California to Colorado, but even if you tried to find populations in Colorado that were really great, there's all sorts of factors that are different. What synthetic control does is it says, let's look at all the possible control populations you have available. Colorado, parts parts of Nevada, whatever you have data on, New York City, all these sets of options. And instead of just choosing one as your control group, create a weighted sample to create a synthetic California app. Take this part of New York City, take that part of Colorado, take this part of Oregon, take this part of Washington, and do kind of like a propensity score match, but on the whole population. And here's the interesting thing. Unlike propensity score matching, they also have a weighted variable included in this method, which helps account for the unobserved confounders. There's a separate weighting that helps you look at how other groups are changing over time due to unknown factors, things that you didn't make explicit, like income. And you create a separate kind of degree of error for that. Then you do the difference in differences between your control population that you've constructed, a synthetic California, and the real observed California. So there you've gained two nice things here. One, you've matched a control population, kind of like propensity score matching. You've matched the whole population to your real one. And two, you've taken into account the fact that there might be unknown factors that influence why a person lives in a particular state or not, or a particular county, a particular city or not. And said, hey, I don't know what these are, but I know that they produce a degree of potential effect, and I'm going to take them into account explicitly. Here's the example with California. So the synthetic California is in dashed line, and the real California is in real line. This is cigarette sales, and I've drawn a vertical line where the proposition was done. Because of the way the data points are, the lines are actually really separating after the proposition. But they're very similar before the proposition, and you can propagate out the degree of effect, the difference in difference, between your synthetic California, which has some of New York City, some of Colorado, some of Utah, some of Nevada, some of Washington State, some of a bunch of different places, in order to make a better control group. The reason I find this particularly powerful for disparities analysis is because one of the biggest challenges for disparities analysis is, by definition, it's at a population level. So you can always propensity score match at an individual level, right? You have this person, you try to find the best match in your data. But at a population level, you're always going to be stuck with this problem that San Francisco, or wherever you are, is unique. And so you're always trying to find a comparable city, or a comparable county, or a comparable state. And at a population level, it's tremendously hard. Right? So if you're comparing disparities as the outcome, the degree of inequality, you're going to be comparing at a group level and need a matched group, which naturally is usually not present. One of the other, any questions about that before I move on? Yeah.
In the slide before, did you, when you, no, sorry, the one with the synthetic California, did you select?
Yeah, how did you do it,
Did you
right?
select the states and then weigh them so that they match the line?
So good question. So yes, you don't select the states. What you provide the universe of available data, and the method does every possible combination of subsets of the data to find the best possible weighted match.
Yes. So the fact that the lines are close together beforehand is saying the program worked. It was able to find something close enough.
Precisely.
Yeah.
And then
So
included in this, which I haven't discussed, are some diagnostics where you can say, hey, have I found a good enough match, to what degree?
Right.
And what's nice about the method is it has a so-called falsification test. That is, it repeats the analysis using every other possible state that didn't have the policy. So it replaces California with real Utah or real Illinois. And then says, how much separation would occur between synthetic Utah and real Utah after California's policy? If there's a major separation, there's a problem. There's a problem. Okay, a so-called placebo test or falsification test, and that's how you can get your significance from there, saying, what degree of error, because of all these unobserved factors, would I observe if I were wrong and there was no real policy there and I falsely thought there was a policy effect?
But Sanjay, does that mitigate the concern you articulated earlier about the sort of the unmeasured inclination, to go on food stamps or not go on food stamps?
Right,
That, or
it's
does that
trying
not?
to capture at least part of it, because it's saying that there's some degree of unknown error here. And by switching the other states around, you say, what degree of imprecision in my policy effect do I get because of those?
Right, right.
And is this substantially a larger effect than just that noise?
If this is too complicated, please move on, but is there a summary statistic that we should teach ourselves to look at or to think about when we look at these studies?
Yeah, it's actually quite simple because this one descends down to the same statistic as the difference in difference. So it's just a regression coefficient. That's the other part I like is it's interpretable. It's just a single, this is how much percent change in your outcome occurred from the policy. Yeah.
The policy itself, in this case, California's tobacco policy was a mix of lots of things. And thinking particularly as you go to other states for comparison, the price differential. Because the policy
Right.
increased the price of cigarettes, and that's known to be probably the most powerful effect of all.
Right.
Well, a lot of the other states already had higher taxes and prices on cigarettes.
Right.
So how do you
So actually that was one of the most prominent weighting variable was actually level of price per pack. So you imagine propensity score matching people not just on their age and sex and stuff, but on the degree of the tax exposure they're receiving. It's actually one of the main variables that's used in the weight because the approach observed that what you're saying is indeed true. So it turns what is a potential confounder into indeed an advantage for you, a way of trying to match people more comprehensively based on what we think are actually influential variables. So one of the dilemmas, and I'll come back to this though, that you sort of indirectly bring up is the policy is also visualizes a fixed point in time here, whereas in reality we know that often these things evolve. There may be degrees of enforcement difference and so on. And also that there's multiple things that we're all calling a policy, but there's multiple components. So I'll come back to that because I think there's a way of trying to dissect that. Into that. So in many cases though, we don't even have the luxury of having a control population set some choice that says I have enough data from outside of my one population to even construct a synthetic control. There are a few options still available to provide some reasonable estimates of your policy effect in that setting. One of the more popular methods, the traditional method, is known as Regression Discontinuity, or RD. And it works as follows. So in a particular province of Canada, the minimum age for purchasing tobacco products was increased from 18 to 21. Okay? And you can see how cigarette sales generally go up with age, but there's a discontinuity there at 21. Those above 21 have this shift, an increase in how much they're purchasing cigarettes. And those below 21 have sort of a decrement, even though some are smoking. There's some effect of the policy which you see as that discontinuity between the two regression lines. Essentially, this is nothing more than doing your linear regression, but you include some threshold, some level at which the policy affects certain people and not others. In this case, age 21 and under is who's being affected and not above 21. A very common example in US-based studies is the federal poverty level being used as a cut point for eligibility into many programs, or 250% or 185% of the federal poverty level. So if you can qualify for a particular program, a subsidy for fruits and vegetable purchases, a welfare program that provides you more income, some sort of employment support program, there's often a cutoff based on what your income is. So you can compare people who are just missed the cutoff to people who just made it as the policy effect. One of the important qualifiers for this is it really is calculating the policy effect for those people who are marginal. That's those people who either barely made it in or not the generalizable policy effect for everyone. So there are some people who are so poor, they're always going to qualify. An analogy is, and one of the first uses of this method, was scholarships and future poverty. So people took what used to be called a PSAT, I don't know if it exists anymore, I'm dating this up. And based on the score that they got in this high school exam, some of them qualified for this National Merit Scholarship. Okay? And some economists wanted to say, hey, let's go follow these kids 20 years out and say, those people who got the scholarship, how are they doing in terms of their future risk of being impoverished or not, or doing well in terms of income and employment and all these things, versus those who missed it. So they compared kids, the testing board said plus or minus 50 on the overall score was considered essentially equivalent scores. And depending on, whether you had a good breakfast that morning or not, you might, as the same person, score plus or minus 50 on the exam. But there's a single cut point for the scholarship. So kids who got 50 points above the cut point got the scholarship, but were more or less the same as those kids who just barely missed it, right, in terms of aptitude, if you believe the test is testing it. So they compared the kids who just barely got the scholarship to those who just barely didn't, and in fact found some profound differences in future earnings and all these other things, suggesting a meaningful effect of the scholarship on their futures. But of course, that doesn't tell you anything about the kid who always scored a perfect, or the kid who always scored a 0. Right? It's the policy effect on the people who are at the margin. Regression discontinuity is really nice for those policies where you have a very clear eligibility criteria to enter into the program. But it's important to do this little test beforehand to see if people being people, and in this case this is a policy affecting young adults do what young adults do. In this case, they create fake IDs. So in the population, there should be a normal Gaussian distribution of age in the sample population. But look, there's a surprisingly unusually small number of people who are between 20 and 21. And a little spike in the number of people who are just over 21 years old. Okay? Unlikely to be demographically true. They've managed to manufacture some IDs in order to purchase tobacco. Okay? So be careful of manipulation, either among participants or just because of lack of clarity or lack of enforcement along the threshold when you're doing a regression discontinuity. There's a way around this called fuzzy RD, not like the George Bush fuzzy math. But it creates a little bit of error around your threshold so that you can say, hey, I still have a policy effect, even though I know that there's maybe some manipulation going on. Okay? Should be like the teachers taking the PSAT from the students kind of problem. One other approach that I think should be adopted as well is if you feel like there isn't a clear threshold, this is often the case. If you look at US welfare reform laws, for example, and you ask, what is the eligibility for welfare? You get a 14-page response, right? Because it's not just income. You're not just poor. You have to be poor with kids in this way, without kids in that way, upside down, purple, or only for a short period and not for a long period, sort of have a job, not really have a job. It's like incredible. There's no clear-cut point in that sense. One technique to deal with these situations, which is quite powerful, and popular in both the sociology and economics literatures, but not so much in public health, perhaps I think due to disciplinary boundaries, is an instrumental variable approach. An instrumental variable acts like a randomizer in your RCT. So you're doing an RCT, you send your enrolled participant over to whoever is the person who's the coordinator for the trial, and the project coordinator flips a coin, or these days uses a computer program, and says, congratulations, you're in the intervention group, or congratulations, you're in the placebo group, right? And people go on their merry way, and in the RCT, you have many people who stay on the placebo group once they're assigned the placebo group, but maybe a few people cheat or drop out or aren't fully compliant to the randomization. And then there's some people in the intervention group getting the new fantastic medication, and some of them adhere, some of them don't. But you do your intention to treat analysis and you treat them as placebo and intervention. Okay? An instrumental variable might be thought of as that randomizing person, but it's something in the environment, some factor in the environment that pushes the similar person towards either being in the social policy or program or being unaffected by it, not participating. For example, in the food stamp example I said, some states happen to fingerprint people on the way to enrollment. That's a nice instrumental variable, even though it's not a nice thing, because a similar person could go into a food stamp office in one state and say, okay, this is the application, fine. And the same person could cross over the border and go through the process and say, and now here's your fingerprinting part, and say, whoa, never mind, this isn't worth it anymore. So it's a nudge into the program or not. Another example is we were trying to study emergency room visits after new housing programs were developed for subsidized housing. But the argument was, well, you know, parents of kids who have really bad asthma may preferentially avoid the public housing because of its stigma and the perception that it's so bad that it's terrible for their asthma. Producing a reverse causal pathway. Those people who have high emergency room visits for asthma are less likely to enter into the housing program. You have this non-randomized selection bias. And there might be all sorts of individual factors that influence whether a person is likely to enroll for a housing program and whether they're likely to have a kid who has bad asthma that ends up in emergency room visits, right? All sorts of social, environmental, neighborhood, personal, household, life course issues. So what can we do? Well, it turns out that the enrollment criteria varies dramatically across states. Kind of like the fingerprinting rules, there's all sorts of different rules that strongly influence whether the same person is willing to go through the application process or not. And you can use that as an instrument by basically saying, what are the levels of housing program exposure I expect based on this randomizer? And then in the second stage regression, you say, based on the expected levels of exposure, how much does that relate to my emergency room visits? The instrument, critically, is something that can't be influenced by reverse causality. Your housing program eligibility criteria are not set by the governor or whoever based on emergency room visits for asthma. And those individual unmeasured characteristics, because the instrument is essentially random from perspective of the health outcome, you've gained that randomization influence where people with different unmeasured confounders are pushed one way or pushed the other. Here's another example from the tobacco literature. Tobacco smoking rates at the county level correlate strongly with cardiovascular disease event rates at the county level, heart attacks and strokes. Great. Well, Altria came back and said, people who have high rates of coronary artery disease are depressed. Tobacco treats their depression. So you found a correlation between tobacco smoking and coronary artery disease rates because we're in fact treating the mental health consequences. And everybody in this room laughs, but how on earth are we going to respond? So you brought up tobacco taxes. Tobacco taxes are a nice instrument. Tobacco taxes are not set by anybody based on local rates of heart attack and stroke. There's no reverse causality there. And tobacco taxes from the perspective of heart attack rates are essentially a random thing in the environment. So you can correlate tobacco taxes being higher with tobacco smoking levels being lower, with subsequent MI and stroke rates being lower. It's an instrumental variable. Something not subject to the reverse causality or those confounders. And then what's Altria going to say? How on earth would tobacco taxes be related to MI and stroke, if not by virtue of smoking being the causal problem? Okay. Instruments, as you can imagine from my example, are A, hard conceptually, and B, hard to think of, right? You have to really know your program well to understand what could possibly be an influence into the program that's more or less random. There is a new approach with instruments that addresses one big problem with instrumental variables, which as shown by my examples, many of them are weak randomizers. If you enter in a trial as a participant, somebody flips a coin and says you're in the placebo group or you're in the new experimental drug group. That's it. It's a hard, single randomizing point. Right? You don't have a choice, more or less, at that point. But instruments are these subtle social things. Whether or not I get fingerprinted during my food stamp application, it'll influence some people, but it's not like the world's biggest influence, right? Some people are like, oh, whatever. And others don't even notice that they haven't been fingerprinted. It's not like it's encouraging them into the program. So what could we do in order to make these weak instruments stronger? Because when you have a weak instrument, your inference then gets lost. It's essentially like not having enough power there to detect your policy. This has been a very long-standing problem, and one of the biggest problems in EPI for instrumental variables, most of the instrumental variables we can think of are kind of wussy randomizers. They're little social influences, but the regression doesn't result in anything much and nothing significant, so we just don't publish it. Right? Near-far matching is an approach that strongly addresses that. Imagine combining the benefits of the propensity score matching with the benefits of an instrumental variable. So first you match people to be as similar as possible in your set. Okay. They're near on all of their observed characteristics, age, sex, race, income, blah, 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 whatever. Just like propensity score matching. But simultaneously, you match them to be very, very different in their value of an instrumental variable. For example, I have a whole bunch of people who are really, really similar in every way who are eligible for food stamps. But they're just across state lines from each other. So in one set is going to get fingerprinted and the other is not as part of their enrollment. What does that do? Statistically, it makes the instrument very strong because people who are really similar, their only difference left over, more or less, is that nudge to enter into the program or not. And so you gain this incredible power. It's kind of like doing a matched pair randomized trial. People are really, really similar in the intervention placebo group, and the only difference is that they get the drug or the placebo. Essentially, it's like making people really adherent to whatever the randomizer told them in the trial. If you're in the placebo group, you religiously take your sugar pills. If you're in the intervention group, you religiously take your new experimental pill. So in a sense, you've constructed power out of nothing, which is kind of cool. An example of where we use this was in that food stamp obesity example. I told you that people propensity scored matched people who were on food stamps found them more obese than their matched population not on food stamps. But there's all these unobserved confounders. The instrumental variable is a random factor. So you gain some of the benefits of randomization, the key to which is those unobserved factors get filtered out. Right? That's why we like randomization. All the unobserved gestalt, how is Berkeley different from San Francisco issues, get randomized evenly between the placebo and intervention group and washed out. So the instrumental variable in this case was the fingerprinting across states. When you included that and redid the analysis, guess what? Obesity no longer significantly different among the SNAP users than the matched non-SNAP users. So it was unobserved confounders, other factors in the environment, things people didn't measure, that was influencing SNAP users to be obese relative to people who seemed similar but were less obese. Questions about that? So, I've said a lot and there's been a lot of terms and methods, but I want to sum up some classical approaches to addressing this issue of social policy evaluation. If you have a nice, lovely control group, which sometimes we're lucky enough to have, the difference in differences approach is often one of the most popular. It's lovely from the perspective of trying to take into account big time trends that affect everybody equally. But oftentimes we need to construct a control group. In this case, matching methods, propensity score being often very popular, or their equivalent, like coarse and exact matching, which just is a little less sensitive to tiny changes, are a nice way of creating a match control group. But remember that it doesn't control for your unobserved factors. Those unobserved confounders, the regression discontinuity, the cut point with the PSAT, or instrumental variables, factors that are essentially random with respect to the health outcome that influence people in or out can help. And there's a few novel approaches that haven't been used very much, but I think are really exciting. Synthetic control, especially if you study big populations or disparities among them, is very nice for that accusation that you're in San Francisco, there's never going to be a control group for you. And the lack of a strong instrument might be resolved through this near-far matching approach where you combine the benefits of matching and instruments. I'll end just by a couple comments about my personal interest in this field is what I would call the temptation of behaviorism. Over the last few years, it's been so difficult to do social policy evaluations on health outcomes that often we resort, or I see myself and my colleagues resorting to what is a little bit easier, which is the smallest incremental level of analysis down from a social policy evaluation. We can't influence fruit and vegetable prices. Let's have a behavioral intervention that does nutrition education. That's fine. It's very NIH friendly. But you can do it in an RCT you just give some people a pamphlet and not kind of things. But it's not really addressing what the social epi literature has told us we're trying to address with regard to the social determinants of health. And so we can always do the next lower down behavioral intervention. Structural intervention is so much harder, but some of these methods might be able to assess the value of the structural intervention. The danger of pre versus post policy analysis, I think the California tobacco example is nice to say. How on earth do we account for time trends? It's very challenging. And so trying to strive for the control group in that setting is quite important. And as much as we talk about ecological fallacies, all these are population level examples, right? So we always have the threat that we're making an incorrect inference because we're at this high level of population study. Counter to that, though, I think we need to be careful about the individualistic fallacy, that whatever is happening at the population level is necessarily just going to be studied by only studying the individuals. Those who study disparities, I don't think I need to emphasize this very much. But the patterning and the social patterning of disease are often quite different between what we would infer from an RCT of a sample and the broader population that we wish to improve health amongst. So I'll end there, and if there's time, take any questions, but thank a few colleagues who worked on these methods, Arjun Siddiqui at Toronto, Mike Baiocchi, who created the near-farm method at Stanford, and Demakani at Hopkins. And please feel free to email if you would like to apply these methods and need a little bit of assist with the right papers or packages and so on. Thanks.